This is a presentation by Bola Olatubosun. Health Promotion and Principles is the name of the unit. My topic is advocacy and activism as an approach to health promotion practice. We'll be looking later at a case study of implementing hygiene community health plan for advocating health issues in Nigeria, including HIV/AIDS. So, by way of introduction, communities are not usually aware of the problems they face and do not know how to tackle this problem. So, at times, it leaves them vulnerable to a lot of social and health issues. Advocacy helps to protect the rights of all the people, either marginalized or vulnerable. Advocacy sits within the community and works with individuals in that community to work out options that will alleviate any crisis situation. So this presentation will look at advocacy as a vital tool for health promotion. As mentioned earlier, there's going to be a case study that talks about advocating community action to improve health issues and the challenges and opportunities of the health promotion practitioner. Practice approach description. Why is advocacy necessary? First on our list is that it's a tool for intersectoral partnerships. Intersectoral partnerships. This is where different sectors come together. Basically, the mainstream like education, health, agriculture, water and sanitation sectors collaborate to identify and solve issues impacting on health outcomes. So advocacy is a great tool for forming such partnerships, bringing all those groups together and to strengthen collaboration. Second on our list is that it eliminates health disparities. Inequities in health come about when resources that enhance human existence are not properly distributed, and this usually affects quality of life and leads to health issues. So advocacy is the voice that speaks for the marginalized to close the gaps and ensure fair and equal distributions of welfare to enhance living standards. The next reason why advocacy is necessary is that it impacts politicians for right policy making. For effective policy making, there needs to be effective advocacy. Effective advocacy would always produce effective policies because advocacy is all about influence. So to advocate effectively, it's important to represent the actual community needs when negotiating with politicians. When policymakers are influenced favorably by community advocates, this influence brings about a change in any given community because the policy will be favorable to the community at large. And last on my list, why advocacy is necessary is because it enables community engagement and capacity building. An advocate not only influences the policymakers but rouses a community to speak with one voice. To represent a community, the practitioner must be able to educate an empowered community to articulate their needs. This empowers individuals in the community as they are able to identify the setbacks, problems, and start working within the community on options for solution. That way they bridge the gap. While doing this, the community is acquiring essential skills of advocacy, dialogue, presentation, negotiation, and overall capacity building. Such empowerment can build a movement that will turn whatever crisis situation that the community was facing into a developmental milestone. We have here a case study of a community health plan that used advocacy, but the visual clip is at the end of this presentation. There was some technical difficulties while attaching it to the presentation slide, so please bear with me and thanks for your understanding. Now we'll move on to the health promotion practitioner and the challenges he could face and the skills needed. One of the challenges is inability to engage the public. With public engagement, the health promotion practitioner should understand community needs and be able to engage with the community. If a practitioner is unable to do this, especially engaging with individuals and stakeholders within the community, then advocacy will not be possible because there will be no way to sieve out the actual needs. It is therefore important to take community engagement seriously, as this is the bedrock of championing the cause of any community. So the engagement should also be timely when started, and the practitioner should disallow gaps, especially while holding stakeholder meetings and collaborating with other partnerships. The skills needed here is empathy, sound communication skills. This is very vital at every stage of community advocacy. Active listening and ability to mobilize community participation is also key. And most importantly, if the practitioner doesn't have ties within that community, if the practitioner has ties within the community, like maybe is from that actual community, then representation becomes easy. The next challenge is lack of research capabilities and evidence-based processes. With research and evidence-based processes, a community in a crisis situation like HIV/AIDS endemic, which we've got cases of it in Nigeria, will be prone to long-term challenges. And in order to formulate long-term plans to deal with it, it's essential to follow processes that will bring about a lasting impact. So if there is no premise to base research on within that community, then models from other communities or other countries can be adopted. The World Health Organization has standards for quality HIV care for developing countries, and there has been trial phases in other countries like Brazil and also in the United States. So these can be built upon while advocating for that organization or that community to facilitate, trials within the community. So it's also important to document results and continue to research on comprehensive strategies for prevention and care. And the skills needed in this area, research skills, and the practitioner should also be able to consider evidence-based processes that has enhanced the efficiency of the particular plans within related specific communities, and also evaluate its practicability in advance on the cost of that community is working in. Usually without this adaptation, like if there's no adaptation, advocacy will not generate the required outcome. The next one is inability to build relationship and capacity. For capacity building, education facilitates the empowerment of any community. So it strengthens locals to participate in the development. This practice engages the community to ask questions, identify problems, and also identify resources at the community level. This leads up to understanding how to source outside resources. This process helps community acquire skills and sharpen knowledge for continuous improvement. So community participation of this sort helps not just for implementation but evaluation and also refining of the methods and procedures used. The skills needed here is that practitioners are expected to be lifelong learners and educators. If you're not able to carry along the community to be a part of the needs assessment application, then there won't be any community participation that fuels the advocacy. The next challenge that a practitioner could face is when they don't have any knowledge of the community terrain, because every community is guided by boundaries and laws, and if a practitioner is not a part of that community, it is important to understand the community systems, the principal actors within the community, the stakeholders, and complete terrain mapping. So also physical terrains like road network, access to transport, most especially in rural settings, and also emergency services available within the area in terms of medical help, walking front lines, and the closest metropolis where mainstream services can be accessed. So without adequate preparedness, most advocacy projects become abandoned projects. The skills needed here is that it's important to define advocacy goals, identify potential problems, policy issues affecting that particular area. It's important to also make short and long-term plans that will target areas of resistance, like when doing the terrain mapping. So this works adequately also when partnering with non-governmental organizations. So here the practitioner should be able to partner with non-governmental organizations and other stakeholders that want to see the change in that community. And the last challenges that we think the health promotion practitioner could be facing is also communication barrier. Communication barrier here could also be language barriers or communication style. It could also be that the practitioner is not speaking for the true representation of the community. So the skills needed is that the practitioner should have a good understanding of the community. There should also be readiness to work with people who will liaise between practitioner and community. This helps to avoid preconceptions or prejudices, as this will form a base of true representation of the community, thereby achieving advocacy goals. Now, the next one is the opportunities of a health promotion practitioner. Advocate and promote self-health practices, work within collaborative and supportive environments, influence on community and policy makers, conduct evaluation and reorientate health services, assess community needs and strengthen community actions, holistic approach in implementing advocacy goals, and is also a key policy driver. In conclusion, the health promotion practitioner is responsible for improving the public health of communities to reduce inequities in health across population groups. This is done through a lot of planning, implementation, and evaluation to ensure that communities are impacted by the right policies. This involves various stages during the stages of development of the project goals, and this can be achieved via advocacy, activism, and lobbying. So the health practitioner's responsibility spans from planning to continuing evaluation. The opportunities embedded herein are massive, so it is necessary that the practitioner develops the core competencies to meet baseline requirements of the health promotion role. Thank you for watching. As said earlier, the case study here is going to be seen at the end of the video. Thank you.
The current state of affairs within Nigeria's healthcare industry highlights that there is still a large amount of work to be done. A look at some of the healthcare indices reveal high rates of maternal mortality, infant mortality, and HIV/AIDS. As a direct response to the healthcare challenges, in 2003, Hygeia Nigeria Limited, a provider of healthcare solutions in Nigeria, and Farm Access Foundation, a multi-services non-profit organization dedicated to expanding access to HIV/AIDS care and treatment in developing countries, embarked on a global advocacy campaign to scale up HIV/AIDS care and treatment within a well-structured and integrated healthcare services model financed through health insurance. Hygeia and Farm Access, together with major Dutch companies working in Africa, promoted the Dutch Health Insurance Fund. The Hygeia Community Health Plan. We commenced the scheme branded the Hygeia Community Health Plan in Nigeria in January 2007. Prior to the scheme's commencement, we had embarked on a process of community engagement, speaking with and establishing relationships with the leaders and various sectors of the community. Initial target group studies were also carried out to identify healthcare buying behavior, premium and subsidy levels, and specific diseases that could be included in the healthcare benefit package. Health checks and community enlightenment campaigns were also carried out during this time as a means of raising the interest levels of the community and garnering their support. The scheme is open to all members of the target communities who wish to and who are actively encouraged to enroll as family groups. Enrollment fees are 200 naira per person in Kwara State and 800 naira per person in Lagos State. The balance of premiums are subsidized up to 95% in Kwara and up to 90% in Lagos by the Dutch Health Insurance Fund. Following the launch of the scheme, enrollment began in earnest. Enrollment. The scheme's enrollment targets at the end of 5 years are 75,000 people in the Shonga community of Kwara State and 40,000 people in Lagos State. We have enrolled over 24,000 enrollees in Lagos and Kwara States combined in 9 months. Utilization. From a utilization of 16 people per month at the Shonga Primary Health Centre prior to the scheme's commencement, figures are up to a current average of over 1,200 people per month. The Kwara State Government has continued in its commitment to the scheme by improving staffing levels and upgraded the facility as deemed necessary from time to time. Infrastructural works have been done around the facility and various medical equipment have been supplied, including laboratory upgrade and the provision of an ambulance. To date, the Kwara State Government has spent over $130,000 on upgrading the primary health facility. Other ancillary benefits like accommodation have also been provided to encourage staff to stay in the community environs and thus become rededicated. The Health Insurance Fund has funded extensive upgrade of some of the private facilities in the areas of structural works and medical equipment donation. Medical equipment such as delivery beds, operating theatre equipment, neonatal equipment, etc. have been donated to the various provider facilities. Providers have also been empowered with information technology through the provision of VSAT connections at the various facilities. The scheme implementers HYGEA and Farm Access also ensure continuous capacity building and year-long monitoring and evaluation by providing quarterly trainings on administrative processes, quality guidelines and medical treatment protocols. Trainings have been conducted in the area of scheme management, maternal care and HIV/AIDS treatment, and scheduled trainings in malaria and childcare have been slated. Community outreach programs are organized to educate the communities on environmental and safety practices to reduce the prevalence of disease such as malaria and HIV/AIDS. The Board of Trustees representing the community, the owners of the scheme, are also empowered to carry out activities to galvanize enrollment and ensure community quality service. 9 months into its commencement, the HYGEA Community Health Scheme continues to grow from strength to strength, with over 24,000 enrolled in Lagos and Kwara combined and over 19,000 patient encounters. Scale-up and sustainability of the scheme are continuously at the forefront of our thinking. It is hoped that other states will join in this revolutionary shift around healthcare thinking and adopt this model as the model for community-level healthcare delivery.